All right, I'm going to call us to order. You could all take your seats. We've got about, I think, about 15 minutes or so for questions and answers and conversation, and just to remind us of where we've been in the last 45 minutes or so. Kent laid out the situation facing the southern states in a series of maps that were maddening and depressing, but showing kind of the state of affairs there, and the disinvestment in education, and a number of problems that are piling on to each other, and gave us a suggestion of 3 or 4 kind of low-hanging fruit opportunities, and really encouraged us to think about systems-level solutions, thinking big, which is a theme that I think has been articulated over the course of the day by many of the presenters and many of the panel members. Terry gave us a flavor for APHA's focus on the connection between education and health, focusing on high school dropout rates, and gave us a great primer on the role of school-based health centers as part of the solution, and emblematic of the kind of collaboration that we can have between health care, public health, population health, and education. And I appreciated that distinction very much, because we do tend to glom all those, conflate all those things together. Then in the last 10 minutes, just really, you took my breath away, Terry, with describing, getting away from talking about poverty as some vague, ambiguous kind of circumstance that people find themselves in, and really rooting us in the facts on the ground, and how what so many of the people that live in this country are struggling with. So really appreciate you doing that. That's where we've been, and let me throw it open to questions, comments, observations from the panel. Ray.
Thank you for great presentations, all 3 of you. I wanted to pursue something that each of you alluded to in some way, but I think Kent hit on directly, which are the implications of the fragmentation of systems. So while in healthcare and to some extent public health, we criticize ourselves all the time for the fragmentation and the lack of integration and so forth, with a few exceptions. Then we devise these grand schemes for how we're going to align with another sector, as if somehow our fragmented system that wants to be more integrated can neatly interface with another system. And Kent talked specifically about the growing fragmentation of the educational system. The same thing is true for the social services system, where we act as though somehow health and healthcare can just connect better with them, and these 2 systems will then do great things together. I wonder if you could say a few more things about, if that's the reality, then what are the implications for how we have to act going forward, and particularly how people on the health and healthcare side need to behave, or what we need to understand in trying to work with the educational sector?
So maybe a month and a half ago, at our offices in Atlanta, we brought together a set of folk from the health sector with a set of folk from the early learning sector, where we actually thought the conditions for interaction between the 2 were favorable compared to anything north of that. Fascinating how long it took. We were there from 10 to 4. And it probably took until after lunch just to resolve language and nomenclature issues, right? So that we were actually in the same conversation. So I think there's a need, that's got to be somebody's task. I guess the point I'm trying to make is to work on. There was a room full of well-intended people, right? Intent is not so much the problem. And there was a wealth of expertise and passion around the table, but we weren't talking to each other until we could get past our codes. That's got to get mediated. Um, um, and and then we got into an interesting conversation about incentives. There were a couple of pediatricians in the room. They spoke in very interesting ways, Raymond, about the changing nature of pediatrics and what the primary care physician is potentially set up to do. Except it doesn't coincide with how they get paid right now. You know, my wife gets paid by seeing somewhere between 25 and 30 patients a day. There are no incentives for her to show up in a school or in a school system to have a conversation about kind of the health determinants of outcomes. So there's a conversation to be had about that too. But the educators in the room were fascinated with what the physicians and healthcare professionals had to say, and vice versa. So we're in a world in which we get trained in highly atomized ways. Our work, our academic and intellectual work, gets rewarded at the level of the individual, not collective effort. There's a lot of, we're very good at taking Humpty Dumpty apart. We're not very good at putting Humpty Dumpty back together again. That's got to be somebody's work. That's got to be somebody's job. It's got to be mediated, I guess, is what I would say. And then I guess finally, we need some well-crafted tests and demonstrations of what putting things back together again actually looks like. We need to watch it carefully. What was hard about that? Yeah. You know, what was easy? So there's, I'm a glass half full kind of guy. Couldn't be here if I wasn't. So I think this stuff can get solved. But a fair test is something that takes time. You know, Laura told you how long they've been at work, building up a logic, testing that logic in field settings, figuring out the language issues, trying to stitch together a wide range of kind of funding streams. You wouldn't do it that way if you had a clean sheet of paper, but we don't.
Terry, did you have?
Yeah, I do.
Please.
Yes, please. So, hi, Ray. How are you? Good, good. So, two things I would like to offer in terms of strategies is one is to engage an education consultant. That's what we did, was to engage someone from the education community who could help translate, help navigate, and teach us that the education community, the education sector, is like any other community. You got to learn the language, you got to learn the nuances, you got to learn the protocols, you got to learn the sweet spots that make sense for them. Learn, and just like any other culture. And so you engage someone from that community as a consultant to advise, to guide, to navigate, to help you move through that world and be somewhat successful in it, is one strategy. The other strategy that we're actually doing right now is working on integrating public health and primary care. Because, speaking to the last part of what Kent said, because of the expectations that are going to be coming down the pike around ACA, there's an interest in how to think about those social factors that are staring everybody in the face. No one wants to identify because they don't know what to do with it. If they do identify that the person is homeless, what do you do with that? And I'm trained as a physician. I'm not trained as a fixer around that kind of a social issue, but I know that that social issue absolutely impacts what I see in the exam room. I know that, but I don't know what to do about it. and even how to ask it. And if you're asking adolescents, if we old folks are asking adolescents, you're not going to get the answer. So it has to be done in a certain way. And so integrating public health and primary care in very deliberate and demonstrative ways gives primary care providers some comfort in asking the questions because they have a response to what they may learn, and recognize that they don't have to be the ones to respond, as opposed to get the appropriate response in the mix. Very different than having to do it yourself, or have your office staff having to do it yourself, or in a school-based health center, being able to ask so that you can bring in the resources that are necessary, or the principal can bring in the resources that are necessary to respond to what you're seeing a trend of. So it's integrating it so that it's takes some of the discomfort out of getting to those social factors. And I believe that in order for you to have better health outcomes, we're going to have to go that way. Because medicine is not going to do it by itself, and education alone is not going to do it. So.
Team sport. George?
So mine's a pretty focused question. You challenged me
To be nice.
to be nice. And actually, this is a question for myself too. I noticed on your slide that Kaiser has several focus areas: healthy eating, active living, and school climate. And Health Partners has a similar list, and I imagine the other care delivery systems have similar focus on. Look, Debbie, of course, has a very robust sort of approach in an awards organization. But I'm asking myself, and I'll ask you now, does that list look, and I don't mean this to be provocative, but maybe it is, does that list look pretty anemic compared to what we've learned today over the course of the day, in the sense of, say, those 7 priorities plus oral health as touch points, or some of the some of the very robust sort of conversation that we've had. And I don't know about what Kaiser has done in terms of determining those 4 focus areas, but I'm also wondering about the method by which we've gone about determining our own focus areas, whether it needs to be a different process to do that. So a little bit of an introspection, but I'll put you on the spot a little bit. I hope that in a very friendly way, but provocative, because I think it's a question that I do this because I think it's a question that care systems in general, looking for a relationship, ought to be asking themselves. So
Yeah,
I hope you don't mind.
Not at all. I welcome it, and I think it's a great and appropriate question. And I suspect Debbie and others will have some responses. So let me answer in this way, which is that it isn't a comprehensive list, and I think the interesting challenge as one organization tries to figure out how to marshal its resources and connect to another setting, another organization. You need to start with the proposition of, what do I have to offer? What is my unique competence, expertise? What are my organizational imperatives? And how can I build a case for connecting to another institution, another setting, another group of stakeholders that in a way that I can actually bring something to the game that matters to my organization and my leadership. And we have some, we have a first way in on and some experience with. So that's kind of how we started with healthy eating and active living, and trying to figure out this school climate net, which is really, really quite large and gets to all the issues that Terry was describing as well. And I'll just reflect on, there's a similar process that every nonprofit hospital went through with the community health needs assessments, where you had to take a list of what the priorities were of the community, look at that list and say, what can I do something about? What makes sense given my organizational capacity, my interest? So it's not just, so there's a prioritization process that takes that into account. So, and that's the beginning. And you get into relationship and you discover other needs that you can identify and work on. But as a colleague of mine that has an Irish accent says, you can't boil the ocean. So, you got to start somewhere, and you might as well start somewhere where you've got some competence. And as Jim Bender's slide showed, a place where schools think that there's some willingness to engage because of the connection between physical activity and time on task and attention and all those other things. So you got to start somewhere that's powerful. That would be my response, and it's the beginning, not the end. But I'll ask my panelists, or Debbie, if you want to kind of opine on that too. It's a fair and good question.
Excellent question. I think, oops, I don't know if this serves a purpose, but okay, I'll put it back. I just want to build on what Lowell was saying, because I think, when we started this 10 years ago, we picked the topic of obesity prevention because it was an area where there was a void. There wasn't anyone in Delaware who was really focused on it for whatever reason. So, it was an area that we decided to focus on, and then we were using it, in a sense, to build our model. So we were, riding the bike and building the bike at the same time. So it was like a test case. And since that time, it's been a combination of proactive and reactive, and being opportunistic, but also recognizing that we are a part of a big clinical operations. And so we also needed to think about how, that nexus between clinical and population health, or primary care and population health, which then led us to the asthma work, which was, was directly related to primary care physicians, and then what we had built up in terms of a capacity in terms of working in the community and doing more of the upstream determinants of health and combining those. And now it's just been a combination of being opportunistic and being also very proactive, and as Lowell was saying, prioritizing all along the way.
Other responses to that provocation or different questions? Sorry, Michelle? Oh, sorry. Jeff, I didn't see who went first. Does anybody have a comment on this last round?
Okay, someone needs to
Jeff,
stop.
put us out of our misery, please.
Okay. So this is a slight change in topic, but I almost raised this when Norris was speaking, but I think it's actually even more appropriate now, given some of the comments Kent made about sort of needing to have non-categorical initiatives. Norris mentioned the community, the school climate transformation grants, not the community transformation grants, the school climate transformation grants, which are actually a collaboration among the Education Department, SAMHSA, and the Department of Justice. But in the peculiarity of our federal system, since they're not authorized to braid or blend that money, actually a community that wants to take advantage of those resources has to apply for 3 different funding streams and account for 3 different funding streams. And as a condition of being funded, you have to apply for all 3 of those applications. So that's sort of I'm saying this, I want to say this in a supportive way. These are 3 agencies that are working really hard to make something possible, but these are the contortions they have to go through, and I think more importantly, the grantees have to go through. And there is no guarantee that just because you've applied for all 3 that you're going to get funded under all 3. So you could still end up with some people funded with some of the funding streams and not the others. Now, there is a different model that took a legislative change, which is a performance partnership grant that is around, it's a performance partnership pilot for disconnected youth that brings together Education, Labor, HHS, the Corporation for National and Community Service, and several other agencies. But because they got legislative authority, it is each of those agencies is contributing. It is one FOA and one process for addressing these issues. And these obviously are issues, they're addressing issues that we've been talking about all day long. So I'm just putting this out there as an observation on comments both from Kent and Norris and others, and all the silo discussion, that there are solutions to some of these silo discussions, And when you do break down those silos, you have the capacity to, when you put money in front of people, they're more likely to come together to create some of these coalitions and to break down and to have people working at the local level in a way that they were not otherwise doing.
I have you've provoked three thoughts with that good example. The first one's this: having been in the government and failed to pull off the comment I'm about to make, it would be fascinating, I think. How you ask for work, how you procure matters. And the crafting of an RFP, the design of a competition matters. It's a pretty hard thing to do. So the first observation I would have about how we procure the work, and so the government could use some advice from bodies like this about things like that, is it takes time to elicit thoughtful responses. And we don't always give the people we're asking to do things the time and information to respond thoughtfully. That's number one. Number two, I've long wished for times when our research agencies were more effectively in collaboration with the program side of the government, because a couple of interesting things could happen if there was more strategic interaction at the stage of design. For starters, the research side could weigh in on designs that yield to generating effects. And that's good to know up front. What are the choices or implications for how you go at this? And number two, since these are competitions, imagine embedding competitive points for projects or initiatives that look like they were going to create opportunities to learn about how these things work. Last point. We have, I think, today in 2014, we've had it for a while, what I call a ratio of ambition to resources problem. Even these promised neighborhoods that we toss around. When I started at MDRC, almost half a decade ago, that place was known for going after an effect. They started with one project called supported work, and they put $80 million trying to answer one question. And now we dangle $3 or $4 million around here. We tell you got 45 days to respond, and you require, collaboration from 5 or 6 different sources and matching requirements. And so the very thing you want to have happen can fall under the weight of all the expectations associated with it, and it's under-resourced before it even gets out the door. And I think if we don't worry a little bit about that, we may take some of the best ideas and suggest them to very poor tests. And then we miss opportunities to learn what it really takes to do really hard things really well.
Okay, so we're not there yet, I guess, yeah. We have about 5 minutes, which I think is going to be enough for 2 questions and quick responses. So why don't we go to Michelle, and then we'll take our last question or comment over here, and I'll ask the panelists to be brief in their responses.
So yesterday and today
and as profound.
have given me a lot to think about, and I think the roundtable a lot to think about. I was struck as you were speaking about the challenges that nonprofits have and government agencies have in sort of keeping the flow of money to the sites once they have a program or a project going. So are you seeing different ways to spread the idea to turn your local champions into advocates for resources, whether it's the school-based health clinic or whether it's actually getting through Kaiser's work, thinking about how you're engaging the school boards and the charter schools in actually wanting to take this on and own it for themselves and find the resources for it. I think one thing that education does, although it does not have enough money, it's particularly skilled at finding resources to do what it believes in. And so I'm curious to know about that spread factor and what you see as the most common challenges and innovations.
Let me try and answer quickly, and if others. I think it's our point of view that public resources are the sustainable resources, and that's the sustainable revenue stream. And in our schools work, there are people that are really important that are working with the school districts at the district level, not the school building level, that we're supporting to identify those resources that currently exist. And to advocate for more sustainable revenue streams. And we saw that in Colorado with the Breakfast After the Bell initiative that just passed, where we had school champions that were very effective in advocating for that legislative change that was described a couple of hours ago. So yes, is the short of it. And absent those kinds of sustainable public resources, we're not going to get PE back into school. We're not going to be able to spread breakfast after the bell in a kind of more sustainable way. And that school building folks are incredible advocates for the kinds of changes that have to happen. Other quick responses?
Yes. So, I think it's on, right? Yes, okay. So yes, to your question about promoting advocacy and building the capacity for advocacy, absolutely. Anybody who knows the work that I've been involved in, we've always go after young people becoming advocates. So those same young people I'm talking about who are distressed by the conditions in their neighborhood, becoming empowered to do something about it, to learn that you have power and you can change the circumstances in your community and make it a learning experience that can be supported by adults, supporting them along the way, helping them to change their environments and not just be victims of their environments. So yes, and yes, and yes. And the other yes to your question about basically what I think you're asking about sustainability is we're very committed to transforming behavior. So when we talk about integrating public health and primary care, so we're talking about delivering the work in a way that it transforms behavior as opposed to giving dollars to do it, changing the way you think about it and approach what it might be. So, for example, real quick, when you talk about, since asthma has come up 100 times in here, recognizing that you can give all the inhalers you want. If that kid has to use a nebulizer and they go home and there's no electricity, they're not going to get their asthma under control, period. Okay? It's not going to work. And so what are the other strategies, whether it be engage in public health to see about maybe that child's home, and they can advocate to see about that child's home, recognizing that there's a medical condition there, and therefore you don't turn off the electricity when there's a medical condition, that's documented with regards to whether it be DTE or whoever the electric provider is, that there's a medical condition so you don't turn off the electricity, or that the school has to be able to let the kid use the nebulizer in the school building. Whatever it is, while the primary care provider may not be able to address the primary care provider can identify it and pull in a public health team to help respond to whatever the it is, because otherwise you're going to have the same kid coming back with out of control asthma over and over again. The home teaching that needs to go along with that so that the family knows what the triggers are that causes that kid to have an asthmatic attack. So that's a public health role. That's a public health response, but you got to engage them in order for it to, so you transform the way that primary care provider thinks about asthma and writing a prescription for the inhalers and the nebulizer. They begin to think about what else is going on in that kid's circumstance that I got to get an intervention on. So that's sustainability. That doesn't need additional dollars, okay, to make that happen. That's transforming the way they practice.
You're creating that culture change, that
Yes.
ability of people and kids to be resilient and their families to
Yes.
be able to be empowered to create the change that
That's
they
right.
would like to see fostered in their communities. So thanks.
Yes.
Thanks to all of you. sorry.
Okay.
So Kent, when you talked about seeing a child in front of you and not thinking about the whole child, but just thinking about the testing, reminded me when my daughter Grace was in 5th grade. We sat down for her report card, and the teacher had not given her a grade on spelling. And we said, well, what's going on with that? She didn't get a grade on spelling. And the teacher said, if I gave her a grade, it would be an F. And if I gave her a grade of F on spelling, it would serve no purpose. But what I am going to do is we're going to do some special interventions with Grace because she had a learning disability and she couldn't spell. But I'm sure that teacher broke some rules and maybe got in trouble because she didn't have all her measures done. My husband saw his primary care doc. He is at risk for cardiovascular disease, but he refuses to take a statin. And now his doc is going to be docked because he's not prescribed a statin that my husband's taking. So I think, here's my reason for telling those stories. I think there's a shared interest in finding the right balance of accountability and measures, but flexibility that health and education share. And is there some way we might work on what are the right measures and accountability among health and education that actually advance what we want, but give us the flexibility to integrate the child and the patient and the family sitting in front of us? So.
You know, I think that's exactly the challenge that the Trust for America's Health and the and their partners in School Matters or Health Matters, the Health Matters campaign is doing, is trying to figure out those accountability systems. The School Health Campaign, I guess, is the other organization. That seems exactly like the right kind of question in the context of this other conversation I know this panel has talked about around accountable care communities and what is the governance structure and the financing structure and the decision-making structure and the shared vision between all these different stakeholders that's required to make that kind of accountability actually work. So a big, big question to kind of end on. I think that, unless you all have, do you have a quick response? And then we'll turn it over to our co-chairs.
I'm scared to now, Lowell. So all I will say, you know, I vote for that sentiment. I would argue that the prize is found if we could start with a set of principles at a high level around which folks could agree, that would be helpful. And then I think we have to have the discipline. I think we're drowning in metrics and indicators. I think we have to have the discipline to arrive at the smallest number of things that make the biggest difference in telling us if we're getting what we want. So I would only have those two additions to, I think, your good point.